I'm June Gruber, an associate professor of psychology at the University of Colorado Boulder and director of the Mental Health Expert Series. I'm here today with Dr. Leanna Clark, the William J. and Dorothy K. O'Neill Professor of Psychology at the University of Notre Dame to talk with her about her cutting-edge research in clinical science and mental health. Thank you for being with us today, Leanna.
I'm happy to do this.
So I was wondering if you could start by telling us a little bit about the kind of mental health research you do.
Well, broadly speaking, I study maladaptive personality, also known as personality pathology and officially called personality disorder. More specifically, I'm interested in figuring out what personality pathology actually is, what the fundamental problems are in people who we say have personality pathology or a personality disorder, and the ways in which these individuals are both similar to each other and different from each other. And in science, of course, the way we define things is not just in words, but by measuring them. So most of my work involves developing and testing ways to measure personality pathology.
Wonderful. How did you go about getting started in this work on personality pathology?
Well, there's a bit of a story to that. Even back when I was in graduate school in a clinical psychology program, I had an interest in personality, which was furthered by the fact that one of the most foremost personality psychologists in the world was a professor there. And I had the good fortune to take a seminar in personality from him, and this is Auke Tellegen. Not long after I started graduate school then, so it's a confluence of events, the DSM-3 was published. And among the many changes in the DSM-3 from the DSM-2, which was a very skinny little book, and then the DSM-3 came out as a big text in this thick, it was the introduction of what was called a multi-axial system. Now, the primary axis encompasses what we think of when we think of mental illnesses: anxiety, depression, schizophrenia, substance abuse, all the well-known, what they call them as clinical syndromes. The second axis concerned problems in individuals' important, long-standing characteristics: intellectual disability and personality disorder. So I was immediately drawn to studying axis 2 because it merged my interest in clinical psychology with my specific interest in personality. And one of the things that I noticed almost immediately was that the way that personality was defined in the DSM was essentially the same as the way personality psychologists define personality. But the catch was the way personality disorder was measured, that is the way that it was diagnosed in DSM-3, was completely different from the way that the psychologists measure personality. I was really surprised by this because I thought it would make sense to measure, that is, diagnose personality in the same way that you defined it. But that's not what the DSM-3 did. So you might ask, how did the DSM-3 measure personality if not in line with its definition? And the answer is that it measured personality disorder following a long-standing tradition in psychiatry. After all, the DSM-3 was written by psychiatrists. And that was to think of mental disorders as categories. Again, think about anxiety, depression, schizophrenia, so on. These disorders are described, assessed, and diagnosed as separate categories. But in contrast, personality psychologists measure personality in terms of dimensions. So we might say that people are extroverts or introverts, and those sound like categories, but it's a simplification of the fact that there's actually a dimension of extrovertedness, introvertedness, that runs from one extreme to the other. Now, if you stop and think about it, it's perfectly natural to describe Mary as more extroverted than Sue, or John as more introverted than Bill. So we think of it naturally as on a dimension, just like we say somebody is tall, but somebody else is taller because height varies. So I decided that I wanted to figure out how to measure personality disorder using the definition that was in the DSM-3 rather than the measurement system that was in there, the diagnostic system. And in a nutshell, that's what I spent the next 40 years doing.
That's amazing. And just as a leader in this area, over the past 40 years, I mean, what are some kind of, points that stand out to you in terms of, frustrations and failures, and or successes that you savored along the way?
Well, they've mostly been frustrations and failures. And that is that the diagnostic system that's entrenched in the DSM is actually still there 40 years later. And it wasn't until DSM-5 that we got any semblance of a dimensional type system of the sort that I believe ultimately is a better way to measure personality disorder. It wasn't until 2013 when finally an alternative model was put in the back of the DSM as a model for people to test and research to see whether it could be moved into the main part of the book. So in between those, I had a lot of success professionally in terms of publishing and all that sort of traditional activities, researching. And within the field of psychology, people began to be convinced. And so that was the big change over the 40 years, is that at first I and perhaps one other person, John Livesley, who I think of as sort of my mentor, were the lone voices in the wilderness calling for a dimensional approach. But by the time it got to DSM-5, it was pretty clear that psychology, at least as a research profession, had been won over. Not entirely, there's still adherence to the categorical method for lots of good reasons, as well as some bad reasons. But the movement had come a long way in 40 years, but I never expected it to take that long because it just seemed patently obvious to me back in 1980.
I mean, so as you see the field, moving forward, even if not at the pace one would expect, I mean, how do you then, looking onto the future horizons, see, or what do you see as the most important steps for the field to go in looking ahead?
Well, one of the really interesting things is that the ICD, the International Classification of Diseases, which is actually the official diagnostic system essentially of the world, because it's put out by the World Health Organization. And the member countries, there's like about 180 member countries, including the US, and that they have agreed by international treaty that they will use the ICD system for reporting disorders, not just mental disorders, but all medical disorders. And that's so that there's a standardized system for studying physical and mental disorders around the world and can have cumulative evidence. Well, in the ICD-11, so the ICD was just revised. In fact, it still has not been finally ratified by the WHO. It will be very, very, very soon. And unlike the DSM process, which has a small body of very selective and trustees who vote on the DSM, it's a particular society, the American Psychiatric Association. The WHO is member countries, so there are delegates from all over the world. And once the work has been done on an ICD, the member countries come to ratify it, and it's pretty much a done deal. It's not like there's suddenly some kind of coup where they decide to change a disorder the way they can in the DSM process. And the point of all of this is that in the ICD-11, the kind of system that I've been working to instantiate for 40 years is fully instantiated in the ICD-11, with one tiny exception that I'm willing to ignore.
I mean, that's wonderful to see that kind of progress being made, especially at such a global level, as you're saying.
Yeah, it's very exciting to me. So I really have shifted my emphasis from working in the DSM to working in the ICD, because I think it's very close to being right. And there's still a lot of empirical questions that we have, but it's so much better than any alternative in my mind, at least.
So then, my final question for you is, what advice would you have for others who are watching this interview today? Maybe they're students, maybe they're scholars, the public, who are interested in this field and maybe even getting involved.
That's a good question and a hard question to answer. Obviously, if you want to get involved in research, it's a long process. You go to college, you go to grad school, you pick a mentor and you get involved. But there's things I think that lay people can do too. And in fact, I think it's really important that the lay public become involved. And I think for too long, our field has been protective of itself, as if we're the only experts. We in psychiatrists are the only experts. Whereas, a matter of fact, everybody knows something about psychology, and it's important, I think, that people educate themselves about health, including mental health, because some of the basics are really straightforward. It's sort of like eat your fruit and vegetables. We all know that as a basic nutritional dictum, but there's some ones for psychology as well, for good mental health. And they begin to seem pat sometimes, I think. Some of it is actually even physical. Get enough sleep, find time for relaxation, develop good relationships. And they seem overly simple, but they're really terribly, terribly important. And I tie this into personality pathology because the fundamental elements of personality pathology involve having a good relationship with yourself and having good relationships with other people. And that's something I think that everybody can work on every day. And it doesn't take a mental health expert to tell you how important it is to love yourself, to forgive yourself, but to continually strive to improve yourself. And the same with your relationships.
Thank you so much. That's wonderful advice. And thank you too for taking the time to speak today, Leanna.
Well, thanks for asking me. I really appreciate it.
Thanks again and have a great day.